Good morning and welcome to the 2022 Los Angeles Global Health Conference. My name is Nafisa Wara. I'm a first year medical student at the David Geffen School of Medicine at the University of California, Los Angeles, and co-director for this year's LAGHC.
My name is Zachary Bango. I am also a first-year medical student at the David Geffen School of Medicine and co-director for this year's LAGHC. Again, apologies for our late start today.
Before we begin, we want to state that the LAGHC committee members at UCLA and the University of Southern California acknowledge the Gabrielino and Tongva peoples as the traditional land caretakers of Tavungar, the Los Angeles Basin, and South Channel Islands. We pay our respects to the Hanukvitam, Ahihirom, and Iohinkim, past, present, and emerging, for the land on which we are living, learning, working, building community, and organizing today.
Beyond today's land acknowledgement, we invite you to learn more about the peoples indigenous to Los Angeles through projects such as Mapping Indigenous LA, to which a link is provided in the program.
We are so excited to welcome you all to the 6th annual Los Angeles Global Health Conference, a conference envisioned, planned, and run by students.
Additionally, we'd like to welcome you to our first ever virtual LAGHC, which has opened up attendance to a broader and more diverse audience from across the globe than any other LAGHC in the past. We have over 500 registrants, and as you can see, attendees are joining us from every continent outside of Antarctica. We are thrilled to have you here with us today.
The past several years, particularly in the global health sphere, have involved a concentrated focus on acknowledging and addressing the colonial and neocolonial roots upon which the field was built and continues to exist. The vast health inequities that exist globally have been brought into even sharper relief by the COVID-19 pandemic.
From amidst and in response, many of our colleagues, academic inspirations, and classmates, many of whom which you will hear from today, have invited the global health community to now push further beyond decolonization as just a buzzword, and we invite you to take on this challenge as well.
For us as the student organizers of LAGHC, we channeled this goal into a conference focusing on sustainability from multiple angles, based on the understanding that global health equity must be rooted in environmentally and systemically sustainable health efforts.
For our 2022 conference titled Sustainability in Motion, we will be highlighting ongoing local and global efforts in developing health systems, community-based partnerships, and climate change mitigation, which propel us towards a more sustainable and just future.
We have a lot of ground to cover in a very short amount of time, so we'd like to provide a brief overview of the day. The conference will consist of 4 hours of conversations with speakers, as well as breaks built in throughout the day. Our opening keynote address will be delivered by Professor Agnes Binawahu. Both keynote presentations will have a short question and answer period at the end of their presentations, where you, the audience, can type your questions in the chat box at the bottom of your screen.
Next, we'll break out into 3 different panels reflecting each of our sub-themes. When these panel rooms open, buttons will appear on the website with each of the panel themes as the title, and we will prompt you to enter whichever room interests you the most. Each panel will consist of short presentations, moderated Q&A, and audience Q&A, where you can type in the chat or unmute to ask your questions. Finally, we'll return to the main room for our closing keynote address from Dr. Cynthia Gonzalez.
Additionally, there will be a networking hour held from 12 to 1 o'clock in the afternoon Pacific Standard Time. There will be 6 optional breakout rooms hosted by student leaders from previous LAGHC years who are active in the field of global health, representatives from USC and UCLA, one of our keynotes, Dr. Cynthia Gonzalez, and several other global and local partners.
As part of this networking hour, we want to highlight a very impressive research in progress presentation that will be delivered during this networking time from colleagues at the Universidad Peruana Cayetano Heredia in Peru. You should have all received a document which contained bios from each host and details which hosts will be in each room. We hope that you will utilize this time to network with both our hosts and each other.
Throughout the conference, there will be a virtual poster and abstract session hosted on our website. Please click on the abstracts and oral abstracts, which are related to our conference theme and sub-themes, and were submitted by trainees from a variety of backgrounds. We are extremely impressed by the breadth and quality of work we've received for this year's conference.
Submissions are from around the country, and we have featured 14 of those projects as posters, which can be found on the LAGHC website, along with their contact information if you have any questions that you would like to follow up. Their abstracts are in your program booklet and on the website as well.
In addition to this, we have selected 6 projects as recipients of the Young Investigator Award as exemplars of scientific research in global health. Their projects are presented as oral abstract video presentations, which you can find on our website as well, along with their contact information. We would like to briefly introduce and congratulate each awardee.
Okay, so first up, we have Nathan Tran, who is a senior at UCLA pursuing a Bachelor's of Science in Human Biology and Society, awarded for his project titled WASH Intervention Through Community Partnership, Assessment of Water Source Quality, Behavioral Changes, and Health in South Central Uganda. Congratulations, Nathan. Next, we have Taylor Pope and Carla Estudio Fuentes, who are based at the Loma Linda University School of Public Health and were awarded for their project titled Malamulo Adventist Hospital and Loma Linda University School of Public Health, a global local partnership addressing malnutrition. Congratulations to both of you. Next, we have Carolyn Smullen, who is a 4th-year medical student at the David Geffen School of Medicine, awarded for her project titled A Qualitative Assessment of Structural Barriers to Prenatal Care and Congenital Syphilis Prevention in Kern County, California. Congratulations, Carolyn. Next up, we have Hubert Tuyashimi, BA, who is an oncology program associate at Partners in Health, awarded for his project titled Authorship, Distribution, and Underrepresentation of Sub-Saharan African Authors in Global Oncology Publications. Congratulations, Hubert. Next, we have John Filosa, Master of Science, who is a 2nd-year medical student at David Geffen School of Medicine, awarded for his project titled COVID-19 Needs No Passport, the interrelationship of the COVID-19 pandemic along the US-Mexico border. Congratulations, John. Next, we have Dr. Margaret Thorpe, MD, MPA, who is a postdoctoral research fellow in the Division of Infectious Diseases at UCLA and former resident physician in internal medicine and pediatrics at UCLA, awarded for her project titled Climate Change, Mobility, and HIV Treatment Disengagement Among Men in Malawi.
Congratulations again to our Young Investigator awardees, as well as our selected presenters, and we invite all conference attendees to take a moment at some point, either during or after today's conference, to browse the incredible global health projects that these researchers are undertaking. Throughout the conference, we also invite you to share your LAGHC experience with your friends and colleagues on social media. Please take photos, share quotes from speakers that you found striking, and tag us on Instagram or Twitter at LA Global Health with the hashtag LAGHC 2022.
Next, we want to extend a huge thank you to the rest of the LAGHC Planning Committee, faculty, and staff advisors who made this conference possible. It's through your hours of dedication and hard work that we've been able to make this day happen. We will wait until our closing remarks to acknowledge all the individuals on our team, but we want to continuously acknowledge the LAGHC team for all their hard work over the past months.
Additionally, we want to acknowledge that this conference would not be possible without our 2 institutional co-sponsors, the USC Institute on Inequalities in Global Health and UCLA Global Health Program. This partnership has been integral to shaping the vision and direction of the conference since its inception, to bring together participants from institutions across Southern California and now the world for a day of learning, discourse, and reflection on relevant global health issues. With that in mind, it's our privilege to introduce Dr. Risa Hoffman from UCLA and Dr. Sophia Gruskin from USC to welcome our keynote speakers for the day.
First, we'd like to introduce Dr. Risa Hoffman, who is the director of the Global Health Program at DGSON. which many of us UCLA medical students are a part of through the Global Health Pathway. She will be introducing Dr. Cynthia Gonzalez, our closing keynote, later in the program. Dr. Hoffman is an associate clinical professor in the Division of Infectious Diseases and an associate director of the UCLA Infectious Diseases Fellowship Training Program. She completed her residency in both internal medicine and pediatrics before moving on to fellowship in adult infectious diseases. She holds a Master of Public Health degree from Harvard University. Dr. Hoffman is incredibly passionate about global health and has worked on HIV-focused clinical projects and research both here in Los Angeles and Southern Africa. For many of us medical students at UCLA, she is one of our greatest mentors and has played a very important role in helping us create the first ever virtual LAGHC.
Next, we are very honored to introduce Professor Sophia Gruskin, who directs and founded the USC Institute on Inequalities in Global Health, or IIGH. She will introduce our opening keynote, Professor Agnes Binawahu. She is the professor of preventive medicine and chief of the Disease Prevention, Policy, and Global Health Division at the Keck School of Medicine, professor of law and preventive medicine at the Gould School of Law, and an affiliate faculty member with the Spatial Sciences Institute at the USC Dornsife College of Letters, Arts, and Sciences. A pioneer in bringing together multidisciplinary approaches to global health, Professor Gruskin's work, which ranges from global policy to the grassroots level, has been instrumental in developing the conceptual, methodological, and empirical links between health and human rights. She created USC's IIGH as a pan-university based upon the foundational concept that global health requires engagement from all disciplines. Professor Gruskin has been a wonderful mentor for us throughout the process of building this year's LAGHC, and we're incredibly appreciative of her support and leadership.
Welcome, Dr. Hoffman and Professor Gruskin.
Welcome, everyone. Good morning from Los Angeles, and good afternoon and good evening to those who are joining from around the world. Really thrilled and so excited to be here today and kicking off the conference as we get started. I just want to start by recognizing the absolutely incredible work of the Student Organizing Committee on putting together this first ever virtual LAGHC. I have been so incredibly impressed with the passion and energy this group has brought, their level of thoughtfulness around the theme, the program, and the speakers. This is a landmark occasion, and they deserve 100% of the credit in making this day come to fruition. I'm going to call out specifically Nafisa and Zach as the co-directors and leaders of this effort. All the members of the committee are listed here, and you'll hear more about them later in the conference. And really, thank you to everyone. It's a dream team. I also want to give a special thanks to our UCLA Global Health Program Coordinator, Vijeta Viswani, who has been in the background supporting logistics and conference operations and day-to-day making this happen as well. So thank you, Vijeta. This would not happen without you. Really pleased to just say a few words about the UCLA Global Health Program. It's funded by the Dean's Office at the David Geffen School of Medicine, and we work closely with medical students, with postgraduate residents and fellows, and other postdoctoral researchers, faculty and staff. And we strive to support equitable partnerships here in Los Angeles and around the globe with a broad focus on health outcomes. One of our key goals is in building community, and that's community here in our own backyard of Los Angeles and the county and globally around the world. And so I'm really especially pleased today to see the wide representation of participants from around the globe, and so grateful that you're joining us to experience this landmark event. During the conference, you'll see during the breaks slide that is posted that has ways to get more information about UCLA and USC, both of our programs, through a QR code. We hope you'll take advantage of looking at our website, signing up for our newsletters, and becoming part of our community as we move into the future. With that, I'll turn it over to my colleague, Sophia Gruskin, for a few words. As many know, there's a very traditional rivalry between UCLA and USC as crosstown universities, and a lot of sports enthusiasts will pick one school and root very hard. But Sophia and I have really tried to work together since we both assumed leadership roles in 2018. And we know that we're stronger together in tackling the problems that we face both here in Los Angeles and globally. And I'm really grateful to have her partnership. And Sophia, turning over to you to do your introduction. Thank you, everybody.
Thank you, Dr. Hoffman. Thank you. And I'm just going to say something very similar, but welcome everyone. It is so great to be here and part of this fantastic conference. You know, the student organizers have been amazing in every way, and I'm so excited for the day ahead. And, you know, my gratitude about this wonderful collaboration between USC and UCLA extends to the students who are putting together this fantastic event, and also just the collaboration between our universities. It's really been amazing over the last few years what we're able to do when we work together in this way. And I just wanted to say that the goals and the approach of the conference are totally in line with the work that we do at the USC Institute on Inequalities and Global Health, and the ethos of how we do our work in bringing together folks from a range of different disciplines, from medicine and from public health, of course, but also everything from law to engineering to social work to communications, much like you will hear today in the way the students have organized this conference. And at USC IIGH, our focus is really to address the disparities, the inequalities, and the broad determinants of health that impact our world. And when I say world, much like Dr. Hoffman was saying, I mean, maybe it's obvious, but LA is very much part of the world, right? And we do this through research and through policy engagement, but also through education and training initiatives. And so I want to strongly, warmly encourage you to sign up for our newsletter and attend also, at least in part, the session at the end of the day to learn more about our work and how you can get involved. The last thing I wanted to say is that, you know, it's a really challenging time for all of us. And moments like this, when we can come together to listen and learn from one another, are so important, more important than they've ever been. And I'm so grateful that this is happening. And I wish everyone a wonderful conference. And I look forward to each session. And I'm now very honored to be able to introduce our keynote speaker, Professor Dr. Agnes Binawahu. There is so much to say about Dr. Binawahu that it's hard to know where to start or, frankly, where to stop. She is Vice Chancellor and Professor of Pediatrics and co-founder of the University of Global Health Equity, an initiative of Partners in Health that is based in Rwanda. Her focus and that of the university is to change how healthcare is delivered around the world by training global health professionals, like all of you here today, who strive to deliver more equitable, quality health services for all. She is Rwandan and a pediatrician who returned to Rwanda in 1996, 2 years after the 1994 genocide against the Tutsi. And her work has been truly inspirational. First in service to her country. She has provided clinical care in the public sector and has served the Rwandan health sector in high-level government positions, first as the executive secretary of Rwanda's National AIDS Control Commission, then as permanent secretary of the Ministry of Health, and lastly as Minister of Health for 5 years. And since co-founding the University of Global Health Equity in 2015, she somehow found time also simultaneously to serve as a senior lecturer in the Department of Global Health and Social Medicine at the Harvard Medical School, as an adjunct clinical professor of pediatrics at Dartmouth School of Medicine, to be member of multiple editorial advisory and director boards, including Think 20, the Rockefeller Foundation, the Africa Europe Foundation, and the Commission on African COVID-19 Response, right? Professor Binawahu is also a member of the US National Academy of Medicine and the World Academy of Sciences, and a fellow of the African Academy of Sciences. She's published over 220 peer-reviewed articles, and she was named among the 100 most influential African women in both 2020 and 2021. We're so grateful she's agreed to join us and so lucky to have her with us today. And with that, Dr. Binawahu, the floor is yours.
Thank you so much for this kind introduction. And also thank you very much to have me with you. It's a very important gathering. So good morning to all of you. Even if it's in Kigali, it's already night. So all of you who are in Los Angeles at the Los Angeles Global Health Conference, I hope to discuss with you with great pleasure this very passionate subject, very important for all rich countries and low and mid-income countries as well. And from here in Rwanda, I'm going to take the example of what I know the best, what is the health sector in my country, Rwanda, and to use it as an example of what it needs to build a health sector. I want to demonstrate that building a resilient health sector, it's not about money, and it's more about having the right vision and use evidence-based scientific approach to implement it. And for this, I will come back in the history of Rwanda 25 years ago, where there was an horrific genocide that killed more than 1 million Rwandan Tutsi, left so many injured, destroyed all the sectors, not only the health sectors, but nothing was standing to serve the population. And after that, I will examine the journey we took with a multi-sectoral approach to rebuild the health sector and how we have made that health sector resilient, and exploring the strategy we have used to make it and how such health sectors have helped us to our response to COVID-19 pandemic. And after that, I will talk to you about how important education is in the creation and the maintenance of resilient health system. What you do in your side and what we do at the University of Global Health Equity. Next slide. So this is just to remind you where Rwanda is, because it's very important. We are a landlocked country. We don't have, everything has to come by road, by sea, by road, by plane, by road. And this is very important to have drugs or tools for medical care. Next. So this is a picture of the country. We call our country the land of 1,000 hills. This is just an example. It's hilly like that from the north to the west to the south, all across the country. We have a very young population. Median age is 20 years. And we are about 13 million inhabitants, highest density in Africa, 525 people per kilometer square. And we have around 18% of our population that live in urban cities. So that means the majority live in places like you can see in this picture in rural area. Our GDP is low, around 800. I just want to give you a comparison. In the US is more than 55,000 per capita. And the main economic activity is agriculture. Next one. So this is important to note. 27 years ago, during 100 days, 1 million people were killed, and more than 3 million people were moved across the country. Everything was destroyed, like I told you, including the health sector. And today, this country is so different that it's a country of hope and brightness. And I will explain to you why. Next. So life expectancy during the genocide, the 1994 genocide against the Tutsi, was one of the lowest on earth, around 30 years of life expectancy. That's very low. And you can see now that we have claimed back, Rwanda, it's in red, and we are above many of our sister countries that have even a higher socioeconomic status than we have. And you will see that the type of development in the health sector we have is key in this result. So next. This is the reduction of under 5 mortality. You can see a peak, dramatic peak around the 1994 genocide against the Tutsi, because everything was destroyed, as I told you. Many health professionals were killed. Others has fled out of the country because they were afraid to be killed, or because they didn't want to answer to the crime because they had killed. So you can see that the dramatic drop we had, and now we are even better than our sister countries. Again, you will see that it's not about money. So in Rwanda, you can see here where Rwanda is. Rwanda has the highest ever drop in under 5 mortality and maternal mortality according to GDP. In the bottom right of these slides, you have the socioeconomic status vertically, and you have the level of drop horizontally. So it's what we call an exemplar country, and it's not the only one. You have also Peru, Senegal, Nepal, Bangladesh, Ethiopia, but you can see that in Rwanda, the drop is the highest for a country with a low GDP, lower than Senegal, Nepal, Peru, Bangladesh. Next. Today, we have more than double the life expectancy. We are around 69, 70 years old. We have reduced maternal mortality by more than 80% and cut infant mortality by 75%. And 91% of our women are delivering with skilled birth attendants in health centers. And still, we have less than $800 per capita. Next. This is the GDP growth over time. You can see that we have around 9.8. Now there is a drop at the end of this slide. This is COVID. As you know, all the world have economic problem today. And you can see that the growth of our GDP is higher than the average of African nation. However, we have very few gold. We are not rich. Our richest is really our people. Next. And this is to show the average GDP per capita in Sub-Saharan Africa in in blue, and the average for Rwanda. So that means it's not because you have natural resources. It's not because you have other type of riches that we don't have, that the GDP per capita will be higher. It's what you do with this money. Next. You can see the life expectancy. The average of Sub-Saharan Africa is in green, and you can see that we are above. And if you can go to the previous slides, you can see that the GDP from Sub-Saharan Africa is far higher than what we have in average in Rwanda. So again, the population health is not necessarily linked to the richness of the country, is what the country does with this with those resources. Next. So we had several strategies to decline poverty. And why I insist on the economic status is because if you want a better population, to improve the population health, you need to break the cycle of poverty and disease. And you can see that in 2001, we had 71% of Rwandans that were poor. Today, just before COVID, we had 55%. So there is a decrease. More than 1 million Rwandans have been pulled out of abject poverty. And this because we had several strategies to fight poverty. And the last one was to fight poverty, for development and fighting poverty. Understanding that you cannot develop if you don't fight poverty. Next. This is to show you the share access to tool of development. And you have this, for this you use access to mobile money, to school, to phone, to market, to healthcare facilities, to etc. And you can see that we follow closely the difference between urban and rural. And this is still showing you that there are still inequities. Not so much, it is decreasing. If I show you that over time, you will see the decrease, but there are still inequalities that we have a long way to go to fight. Next. And this is also to show you that 10%, there is a 10% increase in bank account ownership. We don't think about that, but you know, poverty, ownership, owning your life, is having a bank account make you, give you the opportunity to have a rational way to save money for the day you are sick and seek care. And so the number of people who have a bank account is really followed because this is also a proof of the people owning better their economic status. And you have also access to phone. You can see that 87% of Rwandans have an access to a mobile phone. This is important, notably because if you don't have bank everywhere, you can use mobile money to pay the good you want or to pay for your health services. Next. This is to show you that the human development pillar is a key for our development. And Rwanda has based its development, because we have very little natural resources, on our human development. And if you can see Peru on top in orange, Peru is not a low-income country, it's a middle-income country. And it's just to show you that Rwanda is among the top for the Human Development Index among the poor countries. Next. So this is to situate to you the context of Rwanda. So what are the strategies we have used to build the Rwandan health system and make it resilient? We have used several strategies. The first one, coordinating the donors and the stakeholders around one national plan. But what is important is that national plan was not designed in the ministry, in an office. It was designed with the people, asking them what is their major problem and how we can solve it with the tool we have. It's also a strong community-based health services with 4 community health workers in each village. And those community health workers are elected by the village. A village is around 100 houses. And the village is an administrative entity that is very important. We have a head of village that we elect. I know where my head of village is, even it is a modern village. But all across the country, those entities elect 4 community health workers. We have also a strategy that was collecting and using data, meaning taking evidence-based decision, technical decision, political decision, and a strategy based on equality, but even better, on equity, giving more chance to those who have less. This is equity. Equality is giving the same chance to all. So beyond equality, we have policies and strategies based on equity. Next. The next is accountability. All the leaders at all levels, from the village to the national level, are accountable. I show you down Umushikirano. It's 3 days where everybody come together, all the leaders. So there is no legislative, executive, and etc. We are all together in a place around 2,000, and the population address us with their questions. You commit that, you don't have, etc. And we have to answer. And it's not that it's a blame game, because like when we had COVID, so many things were not done because the money was diverted for responding to COVID, and explain to the population and they accept. We have also the performance-based contract. Everybody signed that contract with the person who supervises, so it's at all levels. All the mayors and ministers and governors sign with the head of state. They sign with all their head of division or directors who sign with all their staff. So up to the village. So everybody commit to key performance indicators. And in the end of the year, it is assessed from people in village to people in sector, district, province, and nationally, people in the ministry, to the staff, to the director, to the permanent secretary, to the minister, to the head of state. And all those indicators are extracted from a national plan. So all Rwandans are working for the same national plan and analyzing who benefits, who is responsible of what, and who is accountable to. And this is the way we have created a culture of accountability. And those performance-based contracts are based on our tradition, where the young warriors, before being considered as a full finished adult, had to commit to something. I will kill 1 lion. I will do this or do that. And he has to come and have fulfilled his promises. And next one. So also the decentralization for geographic equity. In all village, we have 4 community health workers. A couple of villages, an administrative entity called CEL, where you have health posts with a nurse with no degree. Several cells are making a sector. And a sector has a health center with nurses with a degree. That's the place the women deliver. You are hospitalized, they prescribe antibiotic and treat the majority of the disease. And several sectors make a district with district hospital. The first place you have a physician, and each province has a provincial hospital and region referral hospital. So you can see that that's the best way we found to create geographic equity and give the same, at maximum, the same to each Rwandan. But it's not a dream or a paradise, because some districts have a geography that is more hard than another, so it's not really equity, but it's equality in that. Now we have all those levels have their own budget and are accountable to it, from the village, the cell, the sector, the district, and the national level. Next. You have also a consistent and truthful communication. There is nothing more disturbing to the people than different leaders saying different things. So they don't know where to go. And the fact that we have this consistent communication is very important. The next one is no horizontal system, but integration. Every new initiative is integrated with what already exists, and make sure that it is available at less than 1 hour of every citizen. The next one is really adoption of innovation, like drone to deliver blood. We were the first country who did so 7 years ago. And I can assure you, it saved life. Also, the human resource for health. We have using PEPFAR money that was for HIV. We negotiated to use that money in 2012, 10 years ago, to contract 27 high institutions in the US to recruit for a year 100 high qualified teachers to teach our teachers how to teach while teaching our students. And after 7 years, we have managed to create 8 residency, 4 nursing schools, and really increase by 3 the number of medical students and increase the quality of research and education. So those are innovation. When I say innovation, today human resource for health is no longer an innovation. It was an innovation at that time to convince partners to invest in education. It's not so easy. Next. So also, I talked about human development. Education is key, especially when you educate women, you increase the health, population health drastically. The literacy rate has also decreased. It was very high before 2000. Now it's still at 73% of people who doesn't know how to count and to read, but the decrease is high. Next. An equity mind, so every time when you have something new to propose, the question is what it will do for the poor. How is it gender equitable, etc. So that's how we create another innovation, the mutuelle de santé, the community-based health insurance, where people pay according their socioeconomic status. 25% of the Rwandan doesn't pay at all because they are too poor. The government have to pay for them, and it is in the law. And there is money in the law for that. So that means you want to change it, you need to go to our parliament, what is our Congress. Women empowerment, and it works well. We have the highest level, the percentage of women in parliament. 61% of parliamentarians are women, and 55% of women, ministers are women. The geographic equity, I have explained that before. Next. Participatory approach at all levels. Nationally, the election. District level, election of mayor. At sector level, when you have a health center, election of the executive secretary. And the community health worker in your village, you elect them as well. So you are not happy, you can complain. For example, if a community health worker doesn't deliver, the community health worker are elected. Once elected, the Minister of Health have to educate them on their work. So that's not the job of the people in the village. If they're not happy, they just say, we don't want that community health worker. They elect somebody else, and the Minister of Health have to educate that new one. Next. Creating trust. I told you about 27 years ago, the genocide against the Tutsi, the level of trust was so low, 0. We have rebuilt it, creating this system that is inclusive with participatory approach. Even poor. There was a study done by Wellcome Trust for vaccine. And Rwanda is the country where the vaccination of kids is the highest. We have boys vaccinate for 11 antigen, 95% of them, and girls is for 12 antigen because they have HPV vaccine to prevent the cervical cancer. And this is because of trust. So coming from 0 trust, we have managed to have the trust that is the highest in the health sector. We don't say that ourselves. It's Wellcome Trust and Gallup Institute who did that study in 2018. And go back to the previous slides. Trust is key to improve. If you have trust and you share the same what you have in an equitable manner and do your best to bring quality on it, with participatory process and a good communication of what you are doing, you create trust and you build a resilient health system. What is the subject of today? Next. Next. We also use our tradition, homegrown solution based on our culture. For selecting who needs support, we use ubudehe, which is in our culture before the colonial time, a social protection when somebody had his house destroyed by the rain or whatever, all the village was coming to support, to rebuild, and it was called ubudehe. We have transformed that for the people in a village to identify those in need or those who are too poor to have what to feed the kids, etc. We have Umuganda. Umuganda is coming together for a common purpose. It's in our tradition. And we use that every end of the month, the Saturday, to build houses for the vulnerable or do work together. We have internet across the country. But in the beginning, when we didn't have money, all the end of the month, we all come and dig for the fiber optic. So those things come from our culture and we have revigorated. It also the gachacha, the traditional code that have helped us to do in a human way, because we didn't have lawyers, we didn't have judge. At community level, they come together, explain what happened during the genocide, so that the country can create its own justice and take over again. Next. Now we need to sustain those success, and we need to keep progressing. Because if we have a life expectancy around 69, it's still very far than the 80-something that we have in the rich countries. So go ahead. Next. So what we need to succeed is that 91% of Rwandans have a health insurance, that 93% are fully vaccinated, that almost all people diagnosed with HIV are on treatment, universal health coverage for IRVs, and even the people from other countries living in Rwanda permanently are included in that. And we have 91% of women now who deliver in health facilities. We need to keep those success, and we need to go further, because you know that when you control communicable disease, you need to tackle non-communicable disease if you want to continue to increase life expectancy. Next. And also, we all face COVID-19. How did this type of health sector have helped us to the response? So we have prioritized the vulnerable. And today, we have more than 50% of our Africa has less than 10% people vaccinated due to injustice in vaccine distribution, but unethical situation, because even when we pay, there is no vaccine available when the rich country are storing vaccine far more than what they need. However, being one of the poorest countries in Africa, we have managed to vaccinate 50% of our population. What means 70% of the population above 18. We have less than 1,500 deaths. And we have managed to survive lockdown because of this system of head of village and 200 houses identifying the poor and feed them nationally during the lockdown. Of course, they didn't have 3 meals a day, but they had at minimum 1 meal a day for all members of the family. Because we cannot ask poor people to survive a lockdown without food for the well-off to not be infected. So when we cultivate this type of solidarity will have helped us to create the community-based health insurance, that where everybody pay according their capacity to pay and where the poor doesn't pay. When we create that, there is trust. And when science come and say, we better all put a mask to protect each other, population understand that it's for their own wellness, and they don't doubt. And it's very important. Trust allow you to implement evidence-based intervention. Also, to create this type of health sector, it's a multi-sectorial approach. The health sector, the Minister of Health is nobody, can do nothing without the local government where the hospital, the health center, the community health worker live. So we need to work together. As much as also with the Minister of Finance, come together to do those planning and see what is best, where to invest the little money we have to have the best outcome. We did that for COVID-19 as well. And that's how we have a very good response in COVID-19. And next. For this, we use implementation science to respond to COVID. But if you follow what I have said, even we use implementation science to build our health sector. We knew our context. We knew what was the barrier and the facilitators. And we follow the science because we use data. And we use data to monitor what we were doing, to improve what we were doing. And we use strategies that we invent or that we borrow from elsewhere. And because we do monitoring and evaluation, we improve them. That's implementation science in creating a health sector. And with trust, participatory process, and equality, you manage to create a resilient health system. Because during the lockdown, people were so afraid about COVID in the beginning when we didn't know what it was. But they trust and did what was advised, follow science and explanation transparently and consistently. So we knew our contextual factor. We are a low-income country with a little GDP. The majority of people live with informal economy, and 38% were really under the poverty line. So we create strong lockdown, but taking that in account so that nobody was left out of protection. And those who need more protection, like food, etc., were taking account. There are many Rwandan that were not able to pay. So everything was made free the first year. Testing, hospitalization, ICU, you pay nothing. And when you do that, people were not afraid to come, to show up and say, I'm positive, please help me, because it was free and with quality. And let me tell you something. During the first year, the number of tourists were down. So we used the hotels as isolation rooms. So you believe you are in a nice hotel, you are fed, you are cared of by health professionals, and after that you go home. You have you really feel care about. You really feel care of. Sorry, I forgot to close my phone. So the facilitated factors were the strong leadership, the culture of accountability, the equity agenda, and the presence of internet that allow us to follow the people sick, to do contact tracing, and the fact that we had a leadership, a parliament, a Congress that followed the science. And it was not easy because you remember, no masks are needed. A few weeks later, everybody on mask, and go and explain to the population, this is the new science. We're sorry, we didn't know before. So apply everything we manage because of trust. Now, I told you the rate of vaccination we have, more than 70% of people above 80. It's very high for a portion of the world that is neglected. And we have that because the partners give us vaccine because we don't throw them. We don't throw them. And next, and we use them rationally. Now, those strategies that we have used at the time we were building the health sector, they are the same we use for COVID response. Let me show how. The first one, I told you, coordinating donors, one national epidemic preparedness and response plan. Done in advance, we start in December. We even start before because it's not the first pandemic we faced. We had H1N1, we have SARS, and now we have COVID. So we were ready, and even in January, 3 months before the first case in Rwanda, at the airport, all the indication were taking already and the temperature to make sure we can do contact tracing the day a case enter in Rwanda. The strong community-based services, the community health workers were used to sensitize the population and also to follow people that were isolated at home to make sure that they had everything they need. Using data, we can tell you today the number of women and men by district who are sick, who have recovered, who are vaccinated, 1 doses, 2 doses, booster. And also the equity, I told you that everything was free so now we enter in the 3rd year of, we are going to enter in the 3rd year of COVID soon. Up to the 1.5 years, it was free, everything was free for everybody. When the world started moving, we thought that if you have money to take a plane, you have money to pay your test. So now it's still free for the poor in Rwanda. The Rwandan to do a test pay $5, even less than that, etc. So it's according what you can pay. And there's still financial support and food support for the families who still have lost their job. Next. So we have also geographic equity. In the beginning, when we didn't know what COVID was, because we know that the population were totally afraid. If we hospitalize people with COVID in the ordinary health centers and district hospital people will no longer go there and deliver at home. So we turn health facilities, specific health facilities across the country for COVID response. You were suspect or you believe you are infected. You call a free number. People come to collect you with an ambulance specifically for that, bring you for the test. You are positive. You were brought in health facilities that are specifically dedicated to COVID across the country so that the population can still use the primary health services and district hospital without fear. We know that fear was a big issue. Consistent communication. Every day we have a communique of the Minister of Health. And also integration of new initiative in existing initiative. Now that we know what COVID is, it is integrated in ordinary care and the population has got the explanation and are not afraid anymore. And you can see on top of that, we have a national steering committee for coordinating all the activities who answer to the Minister of Health and the Prime Minister. At district level, we have also a district committee and the mayor is important and responsible. And also at all levels, we have such a structure that report to the above structure every day. So that means whole health center in sector report to the mayor at district level, who report to the minister at national level every day. Next. We have also, I told you, innovation. You can see the little robot there who take the temperature and give some, take also some blood pressure, etc. in hospital to compensate the lack of health professional. We don't have enough, and also decrease the risk of contamination. Also, this is a picture taken in the airport. He's going around and I remind you, put your mask, wash your hands, and your temperature is okay. We have also use drone. I told you we use drone for delivery of blood, for example, but also for some vaccine, also for some emergency medicine. And we use them during COVID to give message to the population. The population loves the drone, I tell you. Next. So now we have a resilient health sector. Why? Because we manage to not increase the number of deaths due to other disease, not decrease the delivery in health facilities, the vaccination rate, the basic care and ordinary care has not decreased. And to maintain this, the next step is really to integrate that in your education. So that's how we train all our students in emergency medicine, in response to outbreaks, and also how to build the health sector. Because when I was a young doctor, when I came back, I was a good pediatrician, but I didn't know how to build the health sector. And I was lost because I had no tools to deliver the care I used to provide in Europe. And I had to create the environment needed for me to exercise the clinical care I have learned to provide. So we teach that to our students. And this is the next step to maintain and supporting resilient health system. So you can see down, this is our university in the north of Rwanda. And we have created an university in rural area by purpose. There is a lack of doctors, nurses, lab technicians all over the world. But in rural area, it's worse. And it's like that in your country as well. So the clinical knowledge, the practical skills, the social determinant, all this we teach them. And in a place where they open the door, they are immediately in the community and can apply the community care. We train them to put that in practice using implementation science approach. So this is the University of Global Health Equity. Next. So we have state-of-the-art university, students for all over the world, so far, more than 35 countries. You see 20 countries for some, that was the data of last year. Now we have had 2 new masters, and we have included our neighbor countries in the medical education. Next. We, by purpose, in our medical education, take 70% of medical students as women. That means among all the students who succeed, let's say we have to take 100. We take the 70% best girls and 30% boys. Why? Because we have only 28% of women who are medical doctors in our continent. So this is not equality, this is equity. And it's a statement, because we are not going to change the dawn ourselves, but at least we talk about that, we do it, we walk the talk, and we show it. In other courses, it's 50% minimum. So next. We also educate for free, medical education, again, 6 to 9 years commitment to serve in public service. That means you will get all your money. You will get all your salary and benefit, but you are ready to go and serve in area like the one you have been educated in rural north. Rural north is like any rural poor part of any place in the world. So this is also something important, because if the student had to take a loan to study, it's very difficult in Africa. And also after finishing it study, they will run after money to reimburse, and they will forget to run after social justice, equity, and quality care. Next. I'm ready to take your question, if any. Thank you very much.
Thank you, Dr. Binawahu, for that incredible talk and for giving us such concrete examples of resilient health systems and lessons to be learned. I actually still remember a talk that you gave 4 years ago, and I know that I definitely will not remember what I learned here today. So thank you for that. My name is Shivani Dayal, and I'm a first-year medical student at UCLA and chair of the speaker committee for the LAGHC, and I'll be moderating today's Q&A. So I'll start by asking just one or two questions, and then we'll open it up for questions from our audience. So audience members, if you would like to submit a question to Dr. Binawahu, there is a chat function underneath the Vimeo live stream. There's a chat function in which you can submit questions. It will be reviewed by our team, and you should be able to pop that out into a separate window as well. So Dr. Binawahu, you mentioned so many incredible lessons that can be learned sort of globally. I'm curious, one of our sub-themes that we're exploring today is about partnerships and equitable partnerships. And I'm wondering if you can touch on the role of whether it's academic partnerships or public-private partnerships or other aspects to what makes a sort of strong, equitable partnership in addressing some of these challenges that you have explained, and what does it look like when it's done well?
So I think UGG, the University of Global Health Equity, is the symbol of partnership because it has been created with strong partnership between Partner in Health, which is an American NGO that is global. It's a global NGO in more than 12 countries, and the government of Rwanda, who give the land, the water, the electricity, etc. So it's a private university for nonprofit that is owned by Partner in Health, and Partner in Health is working in 12 countries. Our teachers are coming from all over the world: Asia, Africa, Europe, America, Canada. So it's a global platform. And this is, I think, the future, what will come tomorrow, because we all know that we have to learn from each other. A country like Rwanda, with little money, have done so better than US for COVID. Why? So we have something to learn, to teach. However, for the people who are sick, who need ICU, emergency medicine, etc., we need to learn from countries who knows. So no country, no place have all the full knowledge. It's together that we have the science of the day in action. And this is a moving needle. You know, when you say invite, what I love in your invitation, it was resilience in motion. Sustainability is always in motion because sustainability, you have always more and you have to sustain more for the people. Partnership also. We grow this country with partnership. And I used to say to our friends from the high-income countries, the day we know as much as you, we will go together to countries that we can teach together. So partnership is also in motion. Like Rwanda, we pay back to the world what we receive by other things. We have our people in peace, UN peace for Chad, for Sudan, peacekeeper, because we have a strong things in that. But in all those, we have too few doctors, but we send them and share doctors. This is also partnership. So UGG is a symbol of partnership, owned by Partner in Health, developed with the partnership with the government of Rwanda to change the world.
Wonderful. Thank you so much. That was a very clear and concrete answer to that.
What is important is also that partnership has to be with dignity. No more white savior. Partnership has to be a tool to fight colonialism mindset, you know, and what we call white supremacy, because riches, education, well-off, it's not a matter of skin, of color of skin. It's a matter that the majority of the white people live in place where there is richness, access to education, etc., and former colonialist. So we need to fight any type of supremacy. And this has to be part of any type of partnership.
Absolutely. We have many students who are tuned in today. Do you have any particular comments or advice to some of them on how to make sure that those same mistakes and sort of inequities are not repeated in those partnerships, and how to, if they want to engage in global public health work, how to do that with this mindset?
So first, each and every one have to understand that global health starts where you have your 2 feet. So that means you have vulnerable people, population, people who need you, near you. Don't go and pretend saving people at 1,000 kilometers far from your house when you don't care about those who live near you. So if you do that, it really, there start global health work.
Absolutely. We have some questions that have come in from the chat from those who are listening today. One of them is about what was the, you talked about how trust is such an essential part to implementing any public health measure. And obviously, Rwanda had a particularly important and sort of difficult struggle in regaining that trust. Can you tell us a little bit about what that process was like? What was the biggest obstacle to regaining trust, and sort of strategies that worked well in that particular dynamic?
So the strategy that works well, it is participatory process, meaning having a community health policy that obliges you to include the community in any decision. They are not going to argue with you which type of tablet to take when you have this type of malaria, but you have to explain what to do. And you have to involve them. And when I say giving them a voice at all levels of the health sector, they elect the community health workers, you have the health center, the cell, and there is boards of those health facilities. They have a community member there. And listen to them when they are not satisfied. And even if they are wrong, I remember every year, there is our parliament do an assessment of the some sectors. Health education is always there, and to see if the population is happy. And I remember one year they were not happy with me. You know why? Because they want to have every day a consultation for mother to child to decrease the mother to child transmission, and we cannot do that every day. We did that across the country 3 times a week. And they were not happy because they found that so good, they want that every day. So the problem was not that it was needed. It's not needed. If the women know what day we do that, they will come that day. It's 3 days a week. However, the problem is that I didn't communicate why properly. You understand? So I was guilty of not giving the right information for the people to understand that we were doing our best. So this type of listening and oblige you to the humility to understand that the people are never wrong. You are wrong to not be able to explain that properly. So when people understand that, they start to trust you. So there is a lot of things like that. Give them ownership, give them agency, distribute with equity. Remember when we had only 3 IOVs for 3,000 people, we had 100,000 people sick. How to select? Put the communities in the selection and say who are the most in needed. Please, medically, this is our view. Among them, who to choose. So when you give them agency and ownership, they trust you. And they wait for their turn without being frustrated.
Amazing. I think those were so many valuable nuggets of wisdom in what you just shared. So thank you so much. With that, I'll start wrapping up our Q&A. I know that there are endless questions. We have many more we didn't get to, but I thank you so much for all of your time that you have taken with us today and for your continuous dedication to this incredible work to make the world a better and more equitable place. I would like to take
having me. Thank you for having me. And young people, women like me, men like of my age are ready to go in retirement because you are there. So continue to learn and to do your best every day. Bye-bye.
Thank you so much. I would like to address the audience for a moment and remind everybody that we will now be going into our breakout rooms for each of the panels. You can go to the conference website, LAGHC website, just like you logged in for today's live stream session of our keynote. If you return to that conference page, you will be directed to where you can select one of 3 breakout rooms. One was related to local global partnerships, one about capacity building and health systems, and the third is about climate change. So you can select which room you'd like to be in. You're free to move between rooms as you wish throughout the next hour. We will have a 5-minute break now for you to grab some water or coffee and transition into that breakout room. And each of these panels will have between 2 to 3 speakers who are experts in their field that range from both people working internationally and people working locally, domestically here in the United States and in Los Angeles. So we will have an incredible wealth and breadth of experience that is yet to be shared. So we encourage you all to transition to those breakout rooms now, and we will return back to this live stream feed on our main website for our closing keynote after the breakout rooms. So with that, I would like to once again thank Dr. Binawahu for that incredible keynote. Thank you all for tuning in today, and we look forward to the rest of today's conference with all of you.